Good morning, students. I hope you all are doing well. I'm Dr. Shruti Munjal, Assistant Professor, Department of OBGY. Now I am going to continue with my topic, that is normal labor. This is the second class. We've discussed about what the definition of normal labor. We've discussed maternal pelvis and fetal skull and the mechanism of normal labor and physiology. Now I continue with the topic. So coming to the diagnosis of labor, what are the signs and symptoms of true labor pains? So there are 4 points which define true labor pains. The first one is painful regular uterine contractions. There should be at least 2 contractions in 10 minutes, lasting for around 45 to 60 seconds. The presence of show, as evident by mucus mixed with blood, rupture of membranes where you can see leaking of liquor, and progressive shortening and dilatation of cervix. Now, what are the stages of labor? There are 3 stages of labor. It can be divided in 3 stages: first, second, and third. What defines first stage? It begins with the onset of true labor contractions and ends when the cervix is fully dilated, that is 10 centimeter. Cervical effacement and dilatation occurs in the first stage. The first stage of labor is divided into latent and active. The first stage of labor is the longest for nulliparous and it becomes slightly lesser for multiparous women. Now, what is second stage? The second stage of labor begins with complete dilatation of the cervix and ends with the delivery of the baby. The duration is about 1 to 1.5 hours in nulliparous and around 30 to 45 minutes in a multiparous woman. Third stage. The third stage is that when there is separation and expulsion of the placenta and membranes and also involves the control of bleeding. It begins after the birth of the baby and ends with the expulsion of the placenta and membranes. This is the shortest stage, lasting up to 30 minutes with an average length of around 5 to 10 minutes. There is no difference in duration for nulliparous and multiparous. Now let's discuss what is first stage of labor. Now, what are the phases? As discussed already, what are the phases of first stage of labor? Latent and active. Now, latent phase begins with the onset of contractions and ends when the cervix is 3 centimeter and effaced. Now, what is active phase? Active phase begins after the cervix is 3 centimeter dilated. Now, let's discuss in detail about the latent phase and active phase. Latent phase, it begins with the onset of contractions. It progresses slowly. There is slightly little cervical dilatation. Progressive cervical effacement ends once the cervix reaches 3 centimeter. Now, the duration in nulliparous and multiparous, 8 hours for nulliparous, 6 hours for multiparous. Active phase, there is active progress. It begins after 3 centimeters of cervical dilatation. The period of active cervical dilatation, it should averagely, the dilatation should be around 1 centimeter per hour in a primigravida. And active phase also is divided into 3 components: acceleration, maximum, and deceleration. Acceleration is the slowest phase, and maximum when there is fast dilatation, and after maximum you have a deceleration, whereas there is slow dilatation. Now, what happens in first stage of labor? As you can see in this picture, it's the contraction that has been shown in the graph. You should have at least 2 contractions in every 10 minutes. As I mentioned, and should last for more than 45 to 60 seconds, right? Okay, and now what happens in the first stage of the cervical dilatation effacement? Now, what causes the cervical dilatation? Contraction and retraction of uterine musculature, mechanical pressure by the bulging membrane, the descent of the presenting part. Phases of cervical dilatation: latent phase, the first 3 centimeter of dilatation. It's a slow process. It takes time. 8 hours in nulliparous and 3 hours in multiparous. Active phase, this is active phase, active progress of cervical dilatation. The normal rate should be at least 1 centimeter per hour. What happens during the first stage of labor? This engagement of the presenting part. Do uterine contractions affect fetal heart rate? Uterine contractions can affect the fetal heart rate by increasing or decreasing the rate. Now, what is the normal fetal heart rate? The normal fetal heart rate is 110 to 160. Anything below 110 is termed as fetal bradycardia. Anything above 160 is termed as fetal tachycardia, and which is abnormal. The 3 primary mechanisms by which uterine contractions can cause a decrease in FHR, fetal heart rate, are when there's compression of the fetal head, umbilical cord, or when when there is uterine contraction. Now let's discuss the progress of first stage of labor. Findings suggestive of satisfactory progress of first stage are when there are regular contractions of progressively increasing frequency and duration. The rate of cervical dilatation is at least 1 centimeter per hour during the active phase. When do you say it is unsatisfactory progress? When there are irregular and infrequent contractions after the latent phase, or the rate of cervical dilatation is less than 1 centimeter per hour during the active phase of labor. Now let's come to second stage of labor. Second stage of labor begins with full dilatation and ends with the delivery of the baby. It has two phases, the propulsive phase and the expulsive phase. Propulsive phase, it starts from full dilatation until presenting part has descended to the pelvic floor. Expulsive phase, which ends with the delivery of the baby. Now, what are the features of expulsive phase? The mother's irresistible desire to bear down, distension of the perineum, and you can say anal dilatation. Average length. In primigravida, it is around 40 minutes, multigravida, 20 minutes. How do you decide of the progress of second stage of labor? What is satisfactory? When there is steady descent of fetus through birth canal and there is bearing down sensation for the mother. What is unsatisfactory? When there is lack of descent of fetus through the birth canal and failure of expulsion during the late phase. That's expulsive phase. Third stage of labor. Third stage of labor, it begins after the delivery of the baby and ends with delivery of the placenta and membranes. It has two phases, separation phase and the expulsion phase. The duration is usually 15 minutes or less when you actively manage the third stage. Average blood loss is around 150 to 250 ml. Now, what are the effects of labor on mother and on fetus? In the first stage, there is minimal effect. Second stage, the pulse increases. Systolic BP slightly is increased due to the anxiety and pain. There could be minor injuries to the birth canal. Third stage, the blood loss from the placental site would be there. Blood loss from laceration in perineum, around 100 ml. On the fetus, there is moulding, overlapping of the vault bones, and caput succinium is when there is a soft swelling on the most dependent part of the fetal head. Now let's discuss the management of labor. What are the aims when you're management? Now the aims are to achieve delivery of a normal, healthy baby, to anticipate and recognize and treat potential abnormal conditions before significant hazard develop for the mother or the fetus. Normal labor and principles in the management of labor. The principles include diagnosis of labor, monitoring. You should ensure both maternal and fetal well-being. Management of first stage of labor. On admission, when the woman presents to you in the hospital, you first have to see her antenatal record and to see for any high-risk factors. You should go through all her previous investigations and ultrasound reports. And this is when you get a booked patient in your labor room. When you get a unbooked patient, you would not have any records of antenatal care. So a complete history should be taken. Then you go to the examination of the mother. First, you see for the general condition, evaluate the mother's health condition, look for any pallor, edema, look for an abdominal scar, and check for maternal height and weight. Vital signs, you will go check the blood pressure, pulse, respiration, and temperature. Auscultate the chest and heart and look for any abnormalities. Go for urine analysis for protein, sugar, and ketones. Now, management. After that, you're going to do systemic examination. So, in the abdominal examination, you're going to see the presentation and the position of the fetus, and to check for engagement. Auscultate for the fetal heart rate, and evaluate for the uterine contraction. Vaginal examination. Now, you go for the internal examination. This is done to make the diagnosis of labor. Identify the presentation, to check if the fetal head is engaged, to check for the status of the membrane, whether it has been ruptured or not, to rule out cord prolapse after if there is spontaneous rupture, of the membranes to confirm the degree of dilatation and the position of the presenting part, to check for the progress of labor, to assess the pelvic adequacy, rule out CPD. Bowel preparation: if there are no if there has been no bowel preparation for 24 hours, the rectum will feel loaded, and we do not want to compromise on the posterior space. So you should make sure the bowel is empty. So you can advise the patient for a PC enema. Bladder care: a full bladder may initially prevent the fetal head from entering the pelvic brim, and later it could impede the descent of the fetal head, and which will inhibit the good uterine contraction. The woman should be encouraged to empty the bladder every 1.5 to 2 hours. The quantity of the urine pass should be measured and recorded, and the specimen should be obtained for analysis. Now, what about the nutrition in early labor? It's preferred that you keep her on liquid diet and maintain her hydration. And if the patient is not able to take the liquids orally, then you should go for a IV hydration. And what is the position of the laboring mother? As long as the patient is healthy, the presentation is normal. This engagement, the presenting part is engaged. The fetal heart rate is good. The patient may ambulate. It is not required for her to be to lie down. She can ambulate, which also facilitates uterine contractions. Now, how do you monitor the progress of labor? Once the labor has been established, you have to start your partogram. And through partogram, what you use, you see the well-being of the fetus, the well-being of the mother, and the progress of labor is charted on the partogram. Pain relief: when the patient when the pains are severe, you can offer the patient labor analgesia. So opiate drugs, that is example pethidine, can be given intramuscularly every 4 hours. Inhalational analgesia can be given, and these days epidural analgesia is given. The patient is informed about the choice of analgesia during her ANC visits, and patient is usually counseled and explain the benefits and disadvantages, and the patient is given the option whether she wants to choose it. So usually the labor analgesia is started when she sets into active labor, and when she's around 7 to 8 centimeters, you taper down the medicine, because you need the pain stimulus to encourage the patient to bear down. And as you will come to know in later, when the patients who are given epidural analgesia usually require instrumental deliveries. Now, what causes pain during contractions? So the pain experienced by a woman in labor is caused by uterine contractions and uterine ischemia, and cervical dilatation. The dilatation and stretching of the cervix and lower uterine segments stimulate nerve ganglia and are a major source of pain. The distension of vagina and perineum. Marked distension of the vagina and perineum occurs with fetal descent, especially during the second stage. In first stage of labor, the pain is caused by uterine contraction, thinning of the lower segment of uterus, dilatation of the cervix. Second stage, the painful result of two sources: the stretching of the vagina, vulva and perineum, the contraction of the myometrium. And in third stage, pain is caused by the passage of placenta through the cervix, plus that produced by the uterine contractions. Now, the labor analgesia types are analgesic drugs like narcotics, pethidine, which are given by intramuscular route. Inhalational Entonox can be given, regional, epidural, and spinal is when you have a cesarean section that blocks the sensory pain pathways. Monitoring the FHS. FHS is fetal heart sound. How do uterine contractions affect fetal heart rate? Uterine contractions can affect the fetal heart rate by increasing or decreasing that rate in association with any given contraction. The three primary mechanisms by which uterine contractions can cause a decrease in fetal heart rate is due to the compression of the fetal head, umbilical cord, and uterine myometric vessels. How do you monitor fetal heart rate? Either you auscultate it using a stethoscope, or you go for CTG electronic monitoring. Cardiac topography. In this monitoring, you can monitor the fetal heart rate and its response to uterine contractions. Uterine contraction also can be measured. In a fetal heart rate on a CTG, you can look for the rate, you can look for the acceleration, check for the baseline, you should check see for deceleration, and all these signs will let you know if there is any injury to the fetus. Fetal hypoxia can be checked, monitored. So here you can see how do you record the progress of labor. This is a partogram where you can see on the first half you are going to be monitoring the fetal heart rate. So you can see the figures on the sides, you can see it's 100, 110. On the left hand side it's going, and then you have the alert line and action line. You chart the dilatation and you see the progress of it. This is the alert line, action line. Your patient's dilatation should be charted on the box of this. Then you have the contraction. Good contraction is marked here. Pulse and BP, vitals. Then you have the temperature where you chart in the temperature. Then you have the urine test, the urine analysis. If anything like protein, presence of protein, acetone, and what's the volume is all charted on this. You should always make sure that your cervical dilatation is not, it's on to the right hand side of the what do you say, the line marked. And okay, actually the partogram is a separate topic as a topic in itself. It is to be explained in detail. So this is how you monitor labor. See over here you can see patient information is filled. Fill out the name, gravida, para, hospital number, date, fetal heart rate. It is monitored every half an hour, using a stethoscope. Amniotic fluid, you should record for the color of the amniotic fluid, and you mark it as I if it is intact. You mark it as C if it is clear, if the membranes have ruptured and it is clear fluid. If it is meconium, then you mark it as M, and B if it is blood stain. Moulding, as discussed in the earlier slides. First, grade 1 is when the suture is opposed. Grade 2 when it is overlap but it is reducible, and grade 3 when it is non-reducible. Now cervical dilatation assessed at every vaginal examination marked with a cross. Begin plotting on the partograph at 3 cm. Station is recorded as a circle 0, O at every vaginal examination. Chart contractions are charted every half an hour. Palpate the number of contractions by placing your hand on the fundus of the uterus, and see for tightening of the abdomen, and the duration. So you can see the boxes. If it is less than 20, you're going to mark it this way. If it is between 20 to 40, you draw these lines, and if it is more than 40 seconds, you color the entire box. Then you go for the if the patient is receiving oxytocin, then you record the amount of oxytocin it is being administered. The other drugs, if you're giving any other drugs like you're giving analgesic, pethidine, you mark it on the chart. Pulse is recorded, BP, temperature, and as mentioned, urine report. Management of second stage of labor. How do you manage second stage of labor? Once the onset of second stage has been confirmed, a woman should be not left unattended. Accurate observation of progress is vital, for the unexpected can always happen and you have to be prepared. Maternal position, with the exception of avoiding supine position, the mother may assume any comfortable position which will enhance her bearing down efforts. The semi-recumbent or supported sitting position with the thigh abducted is a posture most commonly adopted. But over here in India, we go for lithotomy position. Bearing down with each contraction, the mother should be encouraged to bear down with expulsive efforts. Now, how do you manage second stage of labor? Observation during second stage. 4 factors determine whether the second stage may be safely continued, and these must be carefully monitored throughout this second stage of labor. Maternal condition observation includes an appraisal of the mother's ability to cope emotionally as well as an assessment of her physical well-being. Maternal pulse rate is usually recorded after 15 minutes, and BP should be recorded every hourly. Fetal condition during the second stage of labor, fetal heart rate should be monitored continuously or after each contraction, and the stage may be associated, and at this stage there could be fetal distress because of the compression on the head and the umbilical cord. The liquor is observed for any signs of meconium. Uterine contraction, the strength, the length and frequency of contraction should be assessed continuously. Now the progress of descent, the progress should be recorded approximately every 30 minutes during the second stage. Conducting the delivery. When delivery is imminent, the patient is usually placed in the lithotomy position and the skin of the lower abdomen, vulva, anus and upper thigh is cleansed with betadine, any antiseptic solution. Now coming to the delivery of the head, they should be control the delivery of the head to prevent any laceration, any perineal tear. Episiotomy is given when you in a primary gravida, you always prefer to go for a episiotomy, which is a plant incision on the perineum, and then you perform the Ridgens method. After the birth of the baby, you clean the airway, clear the airway after the delivery of the head. Now, when do you perform an episiotomy? It is a surgical incision in the perineum to enlarge the space at the outlet. If episiotomy is really needed, episiotomy is said to provide the following benefits. It speeds up the birth, prevents any perineal tear, it protects against future incontinence, it protects against pelvic floor relaxation, heals easier than tears. Management of second, performing an episiotomy. Episiotomies are not always necessary. You should judge from the case. By abdominal examination, you can check for the fetal weight. If you feel the fetal weight is good and the perineum is tight, then you can go for episiotomy. Episiotomy should be considered only in the case of complicated vaginal delivery like breech, shoulder dystocia, forceps vacuum, when there is fetal distress or scarring of the perineum. And what are the types of episiotomy? There's a midline episiotomy, mediolateral and J-shape. The most commonly that we use is mediolateral. Management of second stage, performing before taking an incision, before performing an incision episiotomy, it should first you do is you have to wait for the perineum is thinned out, crowning, and 3-4 centimeter of the baby's head is visible during the contraction. This is called as crowning. And then first you inject local anesthetics, like you used xylocaine, and then you infiltrate the region where you are planning for your incision, wait for 2 minutes, and then you make the incision. Now delivery of the shoulder. Delivery of the anterior shoulder is aided by gentle downward traction. The posterior shoulder is delivered by elevating the head. After the delivery of the shoulder, the baby is grasped around the chest to aid the birth of the trunk. Finally, the body is slowly extracted by traction on the shoulder and lifted, the baby is lifted towards the mother's abdomen. The time of delivery is noted. Cutting the umbilical cord. After delivery, it is therefore usual to wait for 15 to 20 seconds before clamping and cutting the umbilical cord. After cutting the cord, a plastic crushing clamp is placed on the cord 1 to 2 centimeter from the umbilicus, and the cord is cut again 1 centimeter beyond the clamp. Conducting of the delivery, immediate care of the newborn. Once a baby is breathing normally, he should be dried and warmly wrapped to prevent any cooling, and handle to the mother to hold cuddle. If spontaneous respiration is not established soon after birth, resuscitation is the immediate priority. The Apgar score of the baby should be noted and recorded. The mechanism of the normal labor and occipital anterior, I will discuss in the next class in detail, because right now we're discussing about the management of stages of labor. Now we come to the third stage of labor. Delivery of the placenta occurs in 2 stages: separation of the placenta from the wall of the uterus into the lower uterine segment, and actual expulsion of the placenta out of the birth canal. There are 2 mechanisms of placental separation: the Matthews-Duncan mechanism and Schul's mechanism. The leading edge of in Matthew-Duncan's mechanism, leading edge of the placenta separates where are we right now? 1 second. Sorry for the interruption. I'm just wait. Where do we go? Right. The leading edge of the placenta separates first, and then the placenta is delivered with its raw surface exposed. Schul's mechanism: if the placenta is inserted at the fundus and central ileus separates first, the placenta inverts and draws the membranes after it, covering the raw surface like an inverted umbrella type. Now, what are the signs of placental separation? The clinical signs of placental separation are: the uterus becomes globular and hard, There is often a sudden gush of blood. The uterus rises in the abdomen because the placenta, having separated, passes down into the lower uterine segment and vagina, where its bulk pushes the uterus upwards. Cord lengthening, this is the most reliable clinical sign of placental separation. How do you manage third stage of labor? After the placental separation takes place, the placenta can be delivered by passive management, wait for spontaneous expulsion of placenta, or you do an active management. What is active management of third stage? Active management of third stage is the active delivery of the placenta, helps prevents PPH. Active management of third stage, you give use of oxytocin, control cord traction, and uterine massage. Use of oxytocin drugs should be given with the birth of the anterior shoulder. Syntocin is the most used oxytocin. Centrometrin is where there is oxytocin and ergometrin, which is not used in India. We use syntocin in India. And then expulsion of the placenta by active management. When there are signs of placental separation, the patient is asked to bear down and their gentle traction is made. The popular and effective method is Brand-Andrews method. What is Brand-Andrews method? Once the sign of placental separation have occurred, the obstetrician assists the delivery of the placenta by controlled cord traction as described by Brand-Andrews method. Birth of the placenta. The placenta membrane's umbilical cord should be examined for completeness and anomalies. Examination of the perineum. At the same time, the perineal region, vulva, outlet, vaginal canal and the cervix should be carefully examined for any laceration. If the perineum has been torn, an episiotomy has been made, that it should be stitched. I will complete the class over here. Okay, we can discuss about the episiotomy here. You identify the apex and you use a chromic catgut number 1 or 10 and you stitch it in layers. First the mucosal layer, the muscle layer and then the skin. The management after delivery I will take it in the next class as we have one more class to discuss this. So thank you, and I hope if you have any doubts you can call me on my personal number and I shall clear it. Right? Thank you everyone for